Okay, let's move on to another complex area, bipolar disorder. Our sources really emphasize that diagnosis hinges on getting an accurate history of past mood episodes.
Hmm.
The real challenge here, as you know from practice, is how easily hypomania can be missed, or sometimes even misconstrued as just a positive, really productive period.
Absolutely. Patients rarely, if ever, seek treatment for hypomania. In fact, they might feel incredibly productive, creative, full of energy. Why would they complain? It's often only recognized in hindsight, perhaps by family, or when it unfortunately ticks into full-blown mania or crashes into a severe depressive episode. Recognizing it is crucial for an accurate diagnosis, which typically requires a psychiatrist referral, especially for a first presentation or if you suspect it in children or adolescents. As a GP, you're often working as part of that multidisciplinary team, usually in a shared care kind of program.
So how do we differentiate between these different mood episodes? What are the key hallmarks we should be looking for?
Right. Mania is characterized by that abnormally elevated, expansive, or sometimes irritable mood. It's often accompanied by things like accelerated speech, racing thoughts, significantly reduced need for sleep. These symptoms have to last at least a week and cause significant functional impairment. Sometimes it can even involve psychosis. Hypomania is similar, but it's less severe. Crucially, there are no psychotic symptoms, and it lasts at least 4 consecutive days. Still a definite change from baseline, though. Then you have the depressive episodes. These last at least 2 weeks, carry a very high suicide risk, and often present with what we call atypical features, things like excessive sleeping or eating, rather than more classic insomnia and appetite loss you see in unipolar depression.
Given these really distinct presentations, what does this all mean for the general principles of managing bipolar disorder in your practice?
Well, optimal management is definitely multifaceted. It needs to be tailored to the specific mood episode the patient is currently experiencing. Psychosocial interventions like CBT or psychoeducation are absolutely vital for preventing relapse and helping restore quality of life. These should be started early and continued throughout treatment, not just during crises. Psychoeducation for patients and their families is a really key component, helping them understand the illness, recognize triggers, manage symptoms. And another critical point is adherence. Poor treatment adherence is such a common and frustrating cause of relapse in bipolar disorder.
Let's dive into managing those depressive episodes specifically in bipolar disorder, especially given that high suicide risk you mentioned.
Yeah, safety assessment is absolutely paramount because of that high suicide risk. You always need to ask directly about suicidal thoughts. Pharmacotherapy is almost always required for bipolar depression. Monotherapy with drugs like lamotrigine, lithium, or certain atypical antipsychotics like quizartinib or lurasidone is generally recommended first. And this is a really, really critical point for GPs. Antidepressant monotherapy is not recommended for bipolar depression. It can actually induce mania or rapid cycling. If antidepressants are used, they're typically part of a combination therapy, always with a mood stabilizer on board, and the antidepressant is often withdrawn within a couple of months once the mood has stabilized.
Right. And what about for acute mania? That can be a much more urgent, even dangerous situation.
Yes, acute mania often requires urgent treatment, frequently in a hospital setting if it's severe, especially if there's any psychosis or a significant risk to the patient or others. Pharmacotherapy typically involves starting an antipsychotic simultaneously with a mood stabilizer like lithium, sodium valproate, or sometimes carbamazepine. For long-term maintenance, lithium is generally considered the most effective for preventing future manic relapses.
So what about hypomania then? Since it's often missed and less severe, how do we approach managing that?
Yeah, unlike acute mania, hypomania is generally self-limiting and usually not considered an emergency. So it typically doesn't require acute pharmacotherapy unless it's maybe very severe or seems to be rapidly escalating towards mania. Psychiatrist referral is certainly recommended for a proper assessment and ongoing monitoring, though, symptomatic treatment like maybe a short course of benzodiazepines for agitation might be considered in the short term, very cautiously.
Okay, that makes sense. It raises an important question, though. When do we start considering prophylaxis in long-term treatment to prevent future episodes altogether?
Good question. Prophylaxis, or maintenance treatment, is usually considered after 2 or more confirmed episodes of mania or depression, or if even a single episode significantly impaired their function or was particularly severe. Lithium is generally first line for prophylaxis due to the extensive evidence supporting its efficacy, especially for preventing future manic episodes. And importantly, it also seems to reduce suicidal behavior. Lamotrigine is particularly effective for preventing relapse into bipolar depression. The duration of prophylaxis can be quite long, maybe 3 to 5 years, or sometimes even indefinite, depending on the illness severity and frequency. And gradual withdrawal, if attempted, is absolutely essential to minimize relapse risk.
Are there any crucial special considerations for specific patient groups, thinking about, say, young people or patients who are pregnant?
Absolutely, yes. For young people, bipolar disorder is rare and definitely requires specialist child and adolescent mental health services. They are also at higher risk of certain adverse effects from antidepressants and antipsychotics. For example, paroxetine and SSRI should generally be avoided in adolescents due to concerns about increased suicidal ideation in some studies. Managing bipolar disorder during pregnancy is extremely complex and requires specialist input. Sodium valproate, for instance, should not be started in women of childbearing potential without appropriate safeguards due to the high risks of congenital malformations. Lithium carries a lower but still increased risk compared to the general population, and it shouldn't be used during breastfeeding. Agents like olanzapine, campazine, or lamotrigine are often preferred during pregnancy due to having more safety data available. And importantly, something newer in our sources highlights a potential increased risk of neurodevelopmental disorders in children born to males who took sodium valproate in the 3 months before conception. That's a vital counseling point now for men on valproate. And across the board, regular monitoring of drug concentrations where applicable and physical health checks are paramount due to the long-term nature of this therapy.
Okay,